Good evening, or as usual, I should probably say good morning. Um, it's 2 a.m. It's Sunday morning now. I got home a little while ago. It's my last shift for the week. Tomorrow I have the day off, so I figured this was as good a time as any to come down here and record another one of these before slipping off to the land of Nod. I've had an interesting week. I worked for 4 days this week, and that's unusual just in and of itself, but I'm talking about apart from that. This week sort of found me in a bit of a rut, going through the motions of my profession for a large percentage of the time, and kind of using that sequestered part of my brain that I don't need to perform simple procedures to think about other things instead. Things that my brain finds more compelling. And these tend to be things that are largely unfamiliar. This doesn't happen all the time. My job kind of requires most of my attention most of the time. But this week was different for reasons I'll get into shortly. What I'd like to focus on, though, is that idea of the other, the greener grass that our brains inevitably seek out in relatively dormant stretches of time. Why do we do this? I don't pretend to have an answer. It's very unlikely that I'll stumble upon it during this ramble. But that's my focus point. That's my center. So I don't get too far off track. I want to use that idea to sort of align where I'm headed, even though we're not going to get there. So the first part of the equation is the banal. To better understand my specific experience, let me go ahead and tell you a little bit about my week. Really, things have been going this way for a few weeks, and most likely things will continue this way throughout the summer to a greater or lesser extent. But there's a real reason why hospitals tend to be filled with sort of uninteresting injuries around this time of year. There is a best time of the day to go to a hospital. There is a best time of the week to go to the hospital. There's a best time of the month, and there's a best time of the year. And this is easy, or fairly easy to understand once you take a closer look at the reasons why people come to the hospital, especially the emergency room in the first place. So I touched on this a little bit in a previous vlog, but I didn't spend much time on it, so I want to expound on it more now. It was a sort of tangential idea in another vlog, and it took root in my brain, and it's sort of been nagging at me since then. And here's what it comes down to. Here's the nuts and bolts of it. If you could choose a time and a place to be in a health-related, life-threatening situation, your best bet for survival would be, well, obviously to be near a fully staffed hospital, but also to have your event occur in the middle of summer between the hours of 10 a.m. and 12 p.m. Why? Well, there's lots of reasons. Your goal would be to maximize your chances of getting to a hospital where the doctors and nurses were not overtired or overworked and didn't have conflicting priorities. You don't want to arrive at a shift change, but optimally the shift change would have happened at most a few hours prior, because you don't want people to be fatigued. You don't want to arrive at any kind of rush hour. Vehicular injuries spike from 8 until 9 a.m. and again from 5 till 6. And that creates conflicting priorities. When it comes to night, we are creatures of the day, and nighttime is just sort of generally more dangerous as a whole. It's harder to see. We are more tired, etc. There's just more problems at night, so you want to avoid that. You'd probably be safe saying maybe 2 p.m. to 4 p.m. as well. But because of sort of work hours and just sort of more activity during that time, I'm going to stick by my assertion of the morning being intrinsically better. So that explains the time of day, but not the time of year. So why is the middle of summer the best time to find yourself in need of medical care? So one of the things that it's important to understand is that not only are not all patients the same, but their conditions, even if the severity is identical, it's still not the same. A heart attack caused by a blocked coronary artery is very different than a heart attack caused by an electrophysiological arrhythmia. Both of those are of critical severity. Both are cardiac in nature, and both have the same clinical manifestations. To wit, the heart muscle suffers hypoxia from insufficient blood flow. But the treatments are different, and the resource requirements are different. So you can't judge just by the number of severe cases of one type or another. The devil is in the details, and they matter. So, during summer, what you tend to have is an uptick in cases of physical trauma, especially pediatric trauma, as kids are out of school and they're getting up to lots of unsupervised mischief, a lot of which results in physical injuries. In winter, a large percentage of the population is cooped up, so that translates to less trauma. So you're probably saying, well, then you're contradicting yourself, because on the face of it, then it would seem summer would be a bad time to go to a hospital, because the volume of injuries is potentially higher. But like I said earlier, it's not all equal, and it's not just about volume, and there are some mitigating factors that negate and ultimately reverse that supposition. So the first one is that pediatric injuries generally either go to or are routed to a pediatric ER. It's not always the case, but it's enough that it kind of tempers that particular spike. Two, most of the summer injuries tend to fall into the banal category. Falling from a ladder while cleaning your gutters, cutting your leg on with a chainsaw. Let me tell you, We had a lot of windstorms this year, and that translates to a lot of branches on the ground, which translates to a lot of people buying chainsaws, getting excited, thinking that they're Paul Bunyan, going out to their yards and trying to cut up all the branches because, hey, free firewood. And, end up losing a toe or needing stitches in your legs, etc. And fallen branches are actually the worst. They're far worse than, say, trying to cut down a tree because they're loose. So the chainsaw can jam and then it pulls down towards you, or it can jam and then pull you over the branch you're cutting. All these things risk bringing parts of your body into contact with the blade. So we have a lot more of these injuries, but they are of a particular and specific type, where the treatments are straightforward, certainly easy to diagnose. There's nothing hidden about these. We see it and we know exactly what it is. And barring the most horrific of these, there's generally favorable outcomes and good prognoses. And finally, this is particularly applicable anywhere north of Georgia. During the summer, you don't have as many vagrants or the homeless coming in to seek shelter from the cold or with complications resulting from the cold. Our homeless problem here in Baltimore is horrendous. And I've lobbied whatever small ways I can to change the long-term outlook for these unfortunates on a micro level. But right now, the way they survive, one of the ways they survive, is to come into an emergency room complaining of a non-specific injury. Sometimes doing the rotation from hospital to hospital. Some of them have gotten very good at knowing what to say and what not to say in order to get what they want. And, there's no choice there. We have to treat them. We give them beds. We have to fulfill their basic human rights. And many of them have real medical problems, psychological, physical, the gamut. But some of them are either manufacturing a problem to get out of the cold or seeking pain medication. We see that a lot. Those cases can be difficult, and they tie up a significant percentage of hospital staff. So much so that it's actually factored in on a seasonal basis when the board discusses staffing and resource allocation. They refer to it as the homeless bump, which I find disturbingly blasé. And the increase that we get as a result, it doesn't come close to making up for the productivity we lose. Something really needs to be done about it. That's a far larger issue than I came here to talk about. I'm getting off track, but I'm going to file that away. Maybe that's the subject of a future vlog. But back to this one. So the three major issues, those three major issues constitute the reason why it's better, if you have a choice, to come to a hospital in the middle of the summer. And why the middle and not the beginning? Well, some of the things we talked about, like cabin fever, people cooped up for a long time. When they first come out, they sometimes forget how to properly use their bodies. The weather breaks, they need to get outside ASAP, which I understand and endorse. But, you can be a little rusty at your preferred activity for a few weeks, if you're just getting back into it, you might not be in the shape that you were at the start of the previous winter. Those things sort of converge to cause trouble. So ideally, we just put a month's buffer in there and say midsummer to avoid the spike caused by a full winter of lassitude. And then we also avoid the spike of heat stroke that occurs in late summer. I'm telling you, predicting the ebb and flow of people into hospitals is practically an art. But that's pretty much it. Right now, it's still the beginning of summer. Winter this year was rough. It was snowing as late as mid-April. People were getting antsy to get outdoors. All those things together pretty much shaped my week. Lots of physical injuries, not a whole lot of strange or compelling cases wandering in. It was pretty much suture for the majority of my shift, of all my shifts this week, and even the past few weeks. And we had severed tendons, nicked arteries, which can be critical, but it's still a straightforward procedure to correct. The word I think best sums it up is boilerplate. So when you have shifts, or in this case, series of shifts that don't challenge you so much intellectually, it gives you some amount of freedom to let your mind wander, ponder, even mid-procedure, about whatever happens to be brewing in your subconscious at that moment. This week for me, it was kind of meta because it was looking back at the leisurely pacing that allowed me the freedom to examine it. You sort of get in this rhythm where part of your brain checks out and starts doing its own thing. And that part of my brain spent a good amount of time this week wondering about those extremes, those brief bursts of challenge and excitement set against a sort of low noise background of lackadaisical, well-trodden procedures. I called to mind that saying about war, that war is long periods of boredom punctuated by moments of sheer terror. Obviously, that analogy doesn't hold up to close scrutiny, but there are similarities. Both war and an emergency room see a lot of blood, and a lot of times we deflect some of our personal issues with the sort of tension of our surroundings using humor, sometimes crude humor, gallows humor, the whole litany. All to keep the fear and shock of being so ubiquitously close to death at bay. But I came to realize that I think that pacing, that particular pacing, that sort of punctuated equilibrium, is pretty darn close to perfect for me. It's exactly how I'd want all my days to be. As far as I'm concerned, it's ideal. It wouldn't work if it was 50% chaos, 50% quiet. That's not a proper balance because the chaos is far more chaotic than the quiet is quiet. You really need sort of a good 3-to-1 ratio of quiet to chaos. And that's pretty much exactly what I experienced this past week. The right balance, ample time for reflection on the short bursts of chaos. It was pleasant. So, gave you an example or two of the run-of-the-mill cases that I had this week. But let me give you an example of one of the more exciting cases. So this was very early on Thursday morning, 3 a.m., something like that. A 26-year-old female presented with a very high fever, 104. She was being triaged, and while she was being triaged, she started vomiting blood. Now, high fever and vomiting blood, those are sort of triggers for a kind of immediate alert, signaling sort of the potential for a highly infectious pathogen. And it's called vomito negro, and it's black vomit. It's essentially, there are hemorrhagic fevers that cause you to sort of cause cell death along the lining of your esophagus and in your stomach, and you're essentially throwing up. Sorry, this is getting a little bit graphic. Your own sort of insides. So for a variety of reasons, we're sort of on high alert for that kind of thing. So the moment that happened, she went straight to one of the negative air rooms that we have at the hospital I'm at now. A negative air room is pretty much exactly what it sounds like it is. It's a totally sealed space with its own ventilation system, and it keeps the air pressure inside lower than the pressure outside, so that any breaches or undiscovered holes in the space don't necessarily result in the spread of any potentially infectious viruses or bacteria. Air flows in, but not out, at least not out into the hospital itself. The hospital I'm at now has a few of these rooms, not enough for an epidemic, but enough to deal with most situations. So, the reason that I said we're a little jumpy about this, in part, is because recently the Centers for Disease Control put out a MERS warning, and MERS stands for Middle East Respiratory Syndrome, and it can be lethal. So, after the SARS epidemic, the CDC has, good reason to be concerned, and it's great that we're erring on the side of caution. Now, MERS is not SARS. It is not as deadly, but they are not worlds apart. They're both mutations of a strain that started in bats. And I think the MERS fatality rate is about 25%, which is not good, but it's not 80%. So the problem was that the triage nurse, and really everyone in the triage unit, was exposed to this woman's blood. And for a while, we were all extremely concerned about the possible spread of whatever this woman had. So, everybody was scrambling, and luckily the test for MERS is a polymerase chain reaction test. It's a PCR test. Compared to something like a culture, which can take days to get an answer on, a PCR test is quick and precise. And we got a definitive result. Within 45 minutes, we knew that the woman did not have MERS, just bad stomach flu. There's other avenues we were pursuing to see if she was, if it was likely MERS, and she didn't have a history of traveling outside the United States. There's some other things, but you can never be too sure. So for that period of time, it was a really tense hour or so. It's by far the most tense hour of my week. there was the possibility there for a while that we could have been ground zero for a U.S. epidemic of MERS. For the rest of that shift, nothing outside the stable of the ordinary happened. And that gave me the time to think about the nature of infectious diseases and the faults in our procedures that could have allowed an infiltration. My shift that day was 12 hours long, but really felt like it was just that 1 hour. And the rest of my time was spent in quiet reflection. By quiet reflection, of course, I mean, cutting infected tissue away from open festering wounds, cauterizing uncontrollable bleeds, performing spinal taps, things like that. It's all about routine, right? Obviously, if I were a first-year resident, I'd find all or some of those things at least interesting or compelling. But they've become pretty much background tasks for me at this point. Such is life. Malcolm Gladwell said that it takes 10,000 hours to become an expert at something, or about a decade of normal work. It's about right. Most likely because of the diminishing returns of most endeavors. We learn a lot at first, and less as time goes on, as more and more of our tasks related to what we're learning become routine, and we relegate them to the background. They become little more than a well-worn checklist that we hit line by line, while we daydream about our new, true interests. I suppose one could make a comparison with other aspects of human nature. But I think I'm just going to leave it there and get some sleep instead. Pretty tired. So thanks for listening, and have a good night.